Sir has a session elsewhere, so he has to rush. Now we have Dr. Abhijit. He'll be talking about diabetic retinopathy and biomarkers for predicting outcome mainly.
I will try to be as short as possible. So no financial interest involved. And this is the international nomenclature for OCT meeting consensus, normal OCT terminology, and the different layers upon which we will discuss the biomarkers. So diabetic macular edema for treatment purpose, this is a practical thing like tractional detachment, tractional diabetic macular edema, and non-tractional DME. So for tractional DME, we can have VMT, vitreomacular traction, taut posterior hyaloid, epiretinal membrane, and macular tractional detachment, which needs surgery. And for non-tractional DME, there are spongiform edema, cystoid macular edema, and neurosensory detachment, for which medical therapy is the choice. So first and most important and most commonly used is the central subfield thickness. And this is the measured central 1 millimeter of ETDRS circle and indicates increased microvascular leakage and increased CST response better anatomically. Then there is subfoveal neuroretinal detachment. So persistent microvascular leakage causes external limiting membrane breach, which is poor prognostically and responds better to dexamethasone implants. And then we see the next common is cystoid macular edema. The spongiform edema is the earliest pattern of the edema, and fluid accumulates in ONN and OPL, smaller cyst coalesce to form a bigger cyst. So here we can see the spectral domain OCT and retinal thickness map in type 2 diabetes, moderate NPDR. The first one is the before treatment, the next one, the lower one, is the after treatment with a significant decrease in the thickness, and also you can see the cyst disappeared, and also some of the hyperreflective foci also disappeared. And then we come to the drill, that is the disorganization of retinal inner layer. It's a horizontal extent in microns for which any boundaries between the ganglion cell, inner plexiform layer complex, inner nuclear layer, and outer plexiform layer could not be identified within the 1 millimeter wide zone centered on the fovea. So in initial studies, they took the 3 scans above and 3 scans below the foveola, total 7 scans. So here we can see the photographs of 1 millimeter area they measured. And this is the 570 micron of the drill extent, and this is equivalent to the layers they are showing. You can see the OPLI, ONL layers. Here you can see, but here where it is measured as 570 micron, there are 2 arrows. There the layers are blurred, and we just put the normal OCT of the macula, and you can compare with that one basically. And you can have the idea that which layer we are recommending. And change of foveal drill is a strong predictive biomarker for future visual acuity outcomes independent of the central subfield thickness. And for every drill increase of 300 micron at 4 months, visual acuity decreases by 1 line ETDRS at 8 months, irrespective of treatment and CST. Here another photograph you can see, which is showing, it looks like initially it's a drill, but it's a large cyst you can see, which puts the layer together, but you can see differentiate there, them the different way. So this is not a drill. Drill is absent here, and the prognosis is definitely better compared to the last one. So decreased drill is good indicator for visual acuity improvement, and for center involvement diabetic macular edema, strong correlations exist between baseline drill and subsequent visual acuity after macular edema resolution. And pattern of drill resolution appears to be predictive of subsequent visual acuity and likelihood of improvement. Then we find the hyperreflective foci or HRF. They are small dots like opacities less than 30 micron without back scattering, and the reflectivity like nerve fiber layer. And there are some theories how they can be produced there inside, like subretinal lipoproteins or activated microglial cells, and even increased CD4 in aqueous humor also are associated with them. They are biomarkers for inflammation, and they are definitely better response to DEX implants. So this is one of the photographs you can see. This is the multiple HRFs are there. And then here you can see the drill, and this yellow arrowheads showing the HRFs, and these are the cyst, and these are the bridging processes with the green arrow showing them. So other OCT biomarkers, there are plenty. I just put it in the slide. The HRF hyperliptic choroidal foci are there. They are related with the poor prognosis. Bridging retinal processes, they usually denote better prognosis. Then subfoveal choroidal thickness, greater thickness is better. Then PROS or photoreceptor outer segments, less in DR and CME, DME, integrity of ELM, and ellipsoid zone, intact zone is better. Choroidal vascularity index of CVI. Then taut posterior hyaline membrane needs partial vitrectomy. Cone outer segment tip or cost loss denotes poor prognosis. And of course, PAM. In PDR, it can be seen, and also in non-diabetic retinopathy patients, and even when it is the healed DME also, you can see the resolved PAM also. So then the OCT angiography biomarkers we can see. They are the new tools. So they can identify microorganisms, IRMA, CNP areas, NVEs, and there are two things like vessel density. Blood vessel area is to total measured area, which decreased in diabetic patients, where even you cannot find any retinopathy also. And then the intercapillary spacing, early capillary dropouts and ischemia denotes. Then of course the FSZ, and then fractal dimension and 3D perfusion density. Here there is one of the photos. You can see the red is capillary dropouts areas, and the green is the irregular FSZ you can see, and the yellow as the increased intercapillary spacing you can see. So then the last is the autofluorescent biomarkers. Increased fundus autofluorescence denotes the increased central subfield thickness in DME, the worse visual acuity, and are also found in diabetics without retinopathy also. Thank you.
Yeah. Thank you, Dr. Abhijit, for a wonderful session. The drill, I just wanted to add one or two points that sometimes when you try to assess in the setting of a diffuse edema, it may not be so prominent, the disorganization, but the change in drill extent, it happens with anti-VEGF therapy. After the treatment, you feel that once the edema reduces, the drill extent becomes more clearer. So then not only is it prominent during the edema, but then it change in drill extent is a predictive biomarker for predicting the visual acuity as an outcome with anti-VEGF therapy. And also regarding the opta markers that you said, the FAZ enlargement you showed is more, first happens in the deep plexus and then happens in the superficial plexus. So if somebody has a normal looking superficial plexus and his FAZ enlargement happens in the deep plexus, then still that patient can have an improvement in visual acuity with anti-VEGF therapy. It's an early ischemia. So FAZ enlargement first happens in the deep plexus and later comes into the superficial plexus. So that has to be kept in mind.
Yeah, thank you very much, George, for the nice and this thing, very informative, good